prior. And I know this is again going to be an amazing session. And as his topic itself says MSK potpourri, so it sounds only very exciting. So he's going to show you an entire different kind of cases as he was talking about. So it is going to be fun session, I feel. So just a short introduction. He's a very good friend of mine, and except that he's consultant radiologist at Arthro Center at Jyoti Hospital, Gurugram. He has done his MSK fellowship from Innovision Imaging. He has done a visiting fellow in pediatric rheumatology, Germany. His predominant interests are MSK imaging and image guided interventions. He has contributed to various book chapters and is very actively involved with teaching. And thank you so much, Gaurav, for being here, taking time out. And I know it's going to be an amazing session. So thank you once again.
Thank you, Ankita, for the kind introduction, and thank you so much for inviting me again on this platform. I welcome all the delegates and all the residents, the consultants, those who have joined here on this platform. And so we will be discussing various clinical scenarios which we encounter in our daily life. And off and on, there will be a few rare images or cases also which we might see very uncommonly, but we never know when we encounter those. So I think just to have a glimpse of all the imaging modalities together, I would like to share a few cases from my collection. Okay, so as they say that behind every
Voice is cracking. I'm not sure if it's my bad net
mask is a
or everyone
face, and
else.
behind that a story. So we will look at the case. 1 second.
Gaurav, I thought in between the voice just cracked. I'm not sure it was my bad net or it was at your end, but now it's clear again. So all over to you again.
Am I audible
No.
now?
So Gaurav, yeah, they all are also saying that your voice is cracking. Is your net fine?
Oh, just a second. Yeah, the net is working fine.
Yeah, now it's perfectly fine. So I think
But
let's
okay,
start.
okay,
Just
sorry for the
say a
inconvenience.
few words so that we get to know that we are clearly hearing you.
Yeah. So just let me know if there's trouble again. So these are the various clinical presentations which we commonly see in the practice. So whenever a patient comes to you either for an ultrasound or you happen to see before an MRI, so they will either have pain in the wrist, in the shoulder, in the elbow, either in the shoulder region, in the heel, plantar aspect, dorsal aspect. So various clinical presentations come to us to get a diagnosis with a big hope. So I think we are audible now. Am I okay now?
Yes, yes.
Okay. So the first case is of a 28-year-old man who presented with bilateral knee swelling and ankle pain for last 6 months, and he presented to me for an ultrasound of the right ankle. So when I started doing a sonography for this person, so I could see that there was thickening of the synovium in the tibio-talar joint. Okay, so whenever there is a hypoechoic soft tissue which is non-compressible, we label that as synovitis. On the contrary, if there is effusion, that is a compressible area. Okay, so in this patient, we could see that there was synovitis or synovial thickening in the tibio-talar joint, and we could see that there was some ossific spurs or irregularity, some prominence arising from the dorsal talus and the distal tibia. Okay, so as we see, whenever there is synovitis, we just think of two things, either inflammatory or infective, and that's what was going in my mind as well. So along with ossific spurs, whenever we see along with synovitis, so things come like, a degenerative process is going around in the joint. Well, when I saw the next joint, the talonavicular joint, I could see that there was mild synovial proliferation here as well. So after that, I asked him maybe if he has any X-rays along, so that I can see if we have any loose bodies or we can appreciate the bony changes even much better. So on the lateral radiograph, we could see that there was ossific spurs, as we were able to see on the ultrasound, and there was a small intra-articular osseous body, along with the radio opacity here in the joint. So the radio opacity in the joint here, this signifies that there was joint effusion, there was ossific spur, and there was reduction in the anterior tibiotalar joint. So these are the osteoarthritic changes which were more pronounced on the right side. The frontal radiograph was essentially okay. Could not see any significant narrowing of the joint, but the lateral radiograph helped us to clinch a few findings here. So then I asked him if, like, because he also had a knee swelling, so he had knee X-rays as well. Which on my first look, I thought that it's okay. There's no joint space narrowing, and there was small ossific, some small marginal osteophytes coming up, but nothing more than that I could see in my first view. These were the lateral radiographs. So here I could see that there was the patellofemoral joint was absolutely fine. There was no bony fracture, no destructive lesion, but there was large joint effusion in the knee. Again, as I said, so whenever we see synovitis, we tend to think of infective inflammatory, but this was going for 6 months again. So again, so what do I do next? So in this in seeing me in distress, the patient revealed that he has hemophilia with factor VIII deficiency. So my diagnosis was clear that it was a case of an hemophilia-induced arthritis. So then I relooked at the X-rays and I could see that the femoral condyles were broad and widened. So this was a classical case in which there were findings of wide and broad femoral condyles. There was early medial femoral tibial compartment osteoarthrosis. As we could see, there's some osteophytes coming up, and there was slight inward bowing, which is a genu varus deformity developing in this patient. So he was a young chap, 35-year-old with wide and broad femoral condyles, okay, and the large suprapatellar effusion. So I was inquisitive what's there inside. So I did sonography for the knee joint as well, and we could see the beautiful quadriceps tendon attaching at the patella. And apart from that, there was large hemarthrosis in the knee joint. So this was the axial view where we could see all the deposited, the clotted blood and the blood products here. So this was hemarthrosis. And this was the opposite side on the left, which again showed suprapatellar hemarthrosis. So it's an interesting case. Why? Because as a radiologist, it's important for us to mention all these findings so that the patient can be followed up well in time, because preventive therapy is very important in such patients to prevent joint damage. So a study done here, so with under in hemophilic patients, they say that ultrasound is used, at least not in India, but in other countries, as a screening modality to look for how bad the joint is progressing towards a degenerative process or not, and whether it has synovial hypertrophy, destruction of the cartilage, bone damage, and osteochondral damages. So that helps them to decide whether they need a primary prophylaxis, a secondary prophylaxis, or a tertiary prophylaxis. So primary, they do only as a preventive thing when there is no joint damage, but secondary prophylaxis is given after patients experience repeated joint bleeding before the onset of disease. So such patients need appropriate attention and ultrasound monitoring for early detection, management of joint abnormalities, as well as for efficiently tailored therapies. So this was a case of hemophilic arthropathy with synovitis in ankle and hemarthrosis in bilateral knee with early OA or osteoarthritic changes. Okay, so next patient was again an interesting case, a 34-year-old gentleman who had lateral foot pain significantly affecting his activities for over 6-7 months. So I received his MRI almost 6 months back, done in Netherlands, which were not of very good quality though, but it showed insertion like changes like insertional peroneal tendinitis kind of a thing. But because he was not physically seen here, so he tried physical therapy and pain medications there, but he did not improve well. So when he presented to us for an ultrasound, so we could see that because he had a lateral sided foot pain, so our focus was to look at the entire ankle and then the lateral side. So we could see that the peroneus brevis attaches at the fifth metatarsal base. Okay, so this is the cortical outline of the fifth metatarsal. This is the cuboid, and this is the peroneus brevis. Okay, so here we can see that there is irregularity in the cortical outline of the fifth MT. And along with cuboid, there was again a heteroechoic or hypoechoic soft tissue in the joint. So this was a hypertrophied synovium or synovitis, while the tendon looked pretty of good quality, not much affected. So this was irregularity in the fifth metatarsal base, and here we could see that there was increased vascularity in the synovium underneath in the cuboid fifth metatarsal articulation. Along with that, we could see early osteoarthritic changes in the form of osteophytes and some ossific irregularity in the joint. Okay, then while screening other joints, we could see that there was mild synovitis in the fifth metatarsophalangeal joint, while the proximal IP joint was absolutely fine. The peroneal tendons looked healthy, but there was probe tenderness and mild thickening of the tendon sheath. On the longitudinal section, we could see that the tendon looks of good quality, but there was thickening of the tendon sheath with mild fluid. The Achilles tendon was absolutely fine. The calcaneal surface was perfect with smooth outline. The retrocalcaneal bursa, which lies deep to the Achilles tendon, was absolutely normal. So, to my surprise, I asked for the X-rays, and what I could see was that there was some irregularity, which we were seeing on the ultrasound, could be demonstrated here on the radiograph as well, while rest of the bones were fine. So there was a lot of soft tissue swelling, as you all can see here, and along with that, there was enthesitic or enthesopathic changes. So, despite thinking of what it could be, it didn't look like infection. It's going on for 6 months. So, I think whenever you have such a finding, just think twice before you label anything as anything. So, I thought of giving it a possibility of an inflammatory arthritis, but I wanted to rule out an HLA-B27 positive disease. So, based on ultrasound, peroneal tenosynovitis with enthesitis, synovitis along cuboid fifth empty articulation, and so we asked the patient to get a few inflammatory markers to confirm. So CRP was high, 6.5. The rheumatoid factor was fine. ESR was absolutely fine. ANA came out normal. Anti-CCP was normal, but HLA-B27 came out positive. So we were elated when we diagnosed this last year, because this patient was in really bad pain. And after the ultrasound, he straight away went for an MRI. So the images he provided us later on, so we could see all these findings which we saw on the ultrasound on the MRI as well, that there was bone marrow edema here in the fifth MT and the cuboid along with synovitis. Okay, and there was insertional tendinitis of the peroneus brevis. There was fluid in the peroneus longus and brevis tendon sheath, and that irregularity in the bone could be seen here on the gradient images as the irregular cortex here. There was fuzzy outline. And after HLA-B27 positive status came out, so the doctor also advised to get SI joints and lumbar spine screening. So we could see there were small nodes in the lumbar spine, but there were no shiny corners here, and the sacroiliac joints were absolutely fine. There was no marrow edema or no sacroiliitis. So you must be wondering why HLA-B27 and H positive is not affecting the sacroiliac joints. So spondyloarthropathies can be axial or peripheral. Sometimes axial predominates, sometimes only peripheral predominates, and sometimes both axial and peripheral comes together. So the femoral heads in the visualized extent is they were fine. So this is a case of HLA-B27 positive peripheral spondyloarthropathy. The patient's sibling had axial spondyloarthropathy, which he never disclosed us. So until his labs came out positive. So otherwise that would have made our diagnosis or findings much easier to interpret. Next is a case of a 59-year-old gentleman who sustained fall while walking down the stairs, and he had pain on extending the wrist. So he came to me for an ultrasound after 3 weeks of his fall. So there was no immobilization done, and he was absolutely doing his daily routine well with pain. Okay. So when we screened him, he had mild swelling in the wrist region, and as we put the probe on his wrist, we could see that there was a cortical break in the distal radius. So when there was a cortical break, we could, at that time, one should just put some probe to check for any localized tenderness. There was definitely radiocarpal joint effusion. Okay. And on the axial, we could see that there was fracture at the site of Lister's tubercle. So Lister's tubercle is a very important landmark which we use in ultrasonography of the wrist. Okay. So why I'm emphasizing these cases are that in routine practice, every time you will not get an MRI or you don't have X-rays. But ultrasound is one thing which you should all do whenever a patient comes to you. Never be afraid of that. I don't know MSK ultrasound or what. You learn by doing it. Okay. So this was the normal size. This was the left side. The cortex looks absolutely fine. This is the Lister's tubercle, and on the right side, we could see that there was depression, there was cortical break, and this was a site of fracture. The scapholunate ligament and the dorsal aspect, this looks fine. The triquetral, the lunotriquetral ligament was again fine. So this was the X-ray for this patient, where we really could not see a discrete fracture line. But maybe this was a little subtle cortical buckling here, which the orthopedic also missed. So this was a case of subtle fractures of the wrist, and ultrasound comes as a detective shining up. So this was a distal radius fracture picked up on musculoskeletal ultrasound. Okay, this is an interesting case. Again, he's a 35-year-old man who, so all these are stories, which patients tell while we are scanning. So it's always better to talk to the patient, take things out from him so that, at least you win a faith that you are doing the right thing for him, even if you need to get multiple investigations done or for correlation or as a primary one. Okay, so he's an interesting case who hailed from Uttarakhand, and he started developing pain in his ankle 2 years back while he was in Hyderabad. So he stays in the hills. So he said that we don't have much of a facility in terms of transport. So we walk quite a lot, and he has persistent lateral ankle pain for 2 years, so which never went away actually. So the foot and ankle surgeon was to operate him the next day, and he had sent him to me for an ultrasound to rule out what's the status of the bone, is there any callus formation or not. So this was his X-ray from 2022, and here we could see that there's a lucent line between the two bony fragments here, and this was the site of his pain as well. And on the lateral radiograph of the foot, we could see that there's a discrete lucent line here, which is, and here it looks like that it's partially healed, and here this is a non-healed fracture. So this was his X-ray from 2023, which again looks the same, because we could see that there is sclerosis on the inner aspect, while there is a lucent fracture line or a lucent line on the lateral aspect. And this was the time when he came to us. So again, we could see that this line is persistent. So, so when we did his ultrasound, so we could actually see that this is the cortical outline. So we don't see the marrow in on the ultrasound. Marrow is seen on MRI. So only the cortical outline is beautifully seen on the ultrasound. Okay. So so this is the fifth metatarsal base, and this is the bony fragment which we were seeing on the X-ray. And here we could see that there is no discrete callus formation. Rather, the peroneus brevis tendon is coming normally and attaching to the fifth metatarsal base. Okay, so this is another image where we could not see any vascularity or anything like that, just to look for any acute inflammation. And the peroneal tendons were fine. The posterior subtalar joint was absolutely good. So we did, so he had already had a CT scan done before he came to me, but there were no films, nothing. So then when I got some images through a video, so we could see that there was a discrete, a well-corticated osseous fragment adjoining the fifth metatarsal base, which was partially fused to the bone. And as you can see that it has jagged appearance, irregular outlines spiculated, but it is a separated discrete bone, partially united with the fifth MT. So we should be aware of various anatomical variations which occur in foot and ankle. So this is a beautiful article from Insights into Imaging. So it has part 1 and 2. So you can all go through all these normal areas which we should not misdiagnose as pathologies. So this was a case of os vesalianum, which is an accessory bone again. And knowing the history yourself is important while we scan, because see, there is no callus formation. The tendon here is attaching absolutely well at the base, and this has a union with this bone. So this is a partially attached accessory fragment, and the tendon was absolutely fine. So this was not a fracture line. So if we see now, so this is an accessory bone, but because it had some synchondrosis or some attachment, so there was irregularity at its margins. So he went happy. So this is case 5 of a 56-year-old female with right index finger swelling. So history was withheld by the patient until we asked her, and ortho had no clue. She had some skin marks, but the ortho really did not pay attention to what they were. So he just examined that there were finger swelling, difficulty in flexion, and referred to us for an ultrasound. And here we could see that there was thickening of the flexor digitorum superficialis and profundus tendons, the flexor digital tendon, along with moderate thickening of the tendon sheath. So the black thing here is the synovial thickening of the tendon sheath thickening, and the gray color structure, these are the fibrillar tendons. Okay, so the tendons look fibrillar echogenic, while the thickening of the tendon sheath, the fluid appears black or dark or hypoechoic in radiological terms. The white outline is the bone. Okay, so this is the bony outline, and between the two bones is the joint for the ones who are new to this field of radiology. On power Doppler, it showed very trace vascularity, not much, but there was moderate synovitis in the first metacarpophalangeal joint. And along with that, there was tenosynovitis. Here we could see that there's a dorsal osteophyte coming up at the level of proximal interphalangeal joint. The metacarpophalangeal joint was fine. The distal interphalangeal joint showed very trace synovitis, but there was slight irregularity at the DIP joint as well. So these were the skin patches which this patient had. Okay, so she had finger, the thickening of the finger, stubby finger here, and these were the skin patches. So when I inquired her whether she has even more patches, so so then we could actually decode her mystery of joint disease with the skin patch. So she just flexed her elbow and showed she had psoriasis. So this was a case of psoriatic arthropathy in which she had extensive tenosynovitis in her index finger. So and joint synovitis in the metacarpophalangeal joint and OA changes in the interphalangeal joints. So this is another companion case which I saw a few days back. So this patient again thought that she had eczema, but she had pain and swelling in her wrist joint. Okay, but then she was always taking medicines from the Desi doctor, from I don't know even a doctor or not. But then she was just being treated for some allergies, and but she had extensive synovitis in the radiocarpal, the midcarpal, and the carpometacarpal joints. Okay, and there was profuse increased moderate vascularity. She also had swelling around the distal biceps in the at the level of elbow. So we could see that it was degeneration of the distal biceps tendon with tenosynovitis at the insertion. So this is the radius, this is the radial tuberosity, and there was diffuse thickening of the distal biceps tendon. So these are the cases of psoriasis, psoriatic arthropathy, and periarthritis. So it's important to have clinical history. It's important to deduce things out from the patient because they're never going to tell you the truth unless you ask them and trigger them to speak something. Next is a case of a 39-year-old female who presented with pain in the second toe tip. Yeah, so this is interesting, which I saw for the first time and had to really break my head against against the wall. And but the patient actually, as you talk to the patient, you call them if they are well cooperative, the diagnosis become easy. So 39-year-old female second toe tip came for MRI of the foot late in the evening. No history taken, no X-rays, nothing available. So once we start reading it, whenever we see something in the joint, we label that as inflammatory, infective, and whatnot. Okay, so there was a nodular soft tissue thickening in the metatarsophalangeal joint, but it was just not thickening. It had some, something like rice bodies or something like punctate hypointensities or hypointense dark foci in the joint. So there was another area where the bone was scalloped, and we could see that there was soft tissue thickening, kind of a synovium, maybe, I don't know, along with hypointense areas. And there was scalloping of the bony outline here as well. Okay. Next, what we see was that it was extending in the web space and extending beneath the extensor tendon sheath. So it was going in the joint, causing scalloping. It was weird. Next area which I saw, because this was her area of concern. So this was again a lobulated T2 bright area lesion in the toe causing scalloping of the distal phalanx. So again, not sure what it was. So it really did not look like inflammatory or infective arthritis to me. And we try to call away the patient. So these were the post contrast images. So these areas got good enhancement in the post contrast images. All the three looked same here, but on request, the patient handed up to us finally. So these three areas were evaluated again on ultrasound, and specifically this area because she was not even allowing us to touch. Okay, so on ultrasound, what we did was we could see a soft tissue with multiple calcific areas or ecogenic areas. So again, we were clueless what it is. So this was in the area of web space and it was going inside the joint. We could see that there was some fluid inside the joint, some osseous irregularity here. The joint was distended again. Okay, so this was the area in from the MRI, so which was scalloping the bone on the undersurface. So this was again of the same morphology as we see the above lesion. Okay, so this is which is at the terminal tuft of the second toe. So this has a different imaging morphology as compared. So if you see these lesions, these are hypoechoic with punctate calcific areas or calcifications, but this area is hypoechoic and dark. And when we are putting Doppler, we could see vessel going through it, and it was extremely tender to touch, and it showed vascularity with arterial venous waveform. So this was the typical, this was like, this is the exact site where she had this soft tissue swelling. So surprising, the husband said that she has been operated around 2 years back, and they had a biopsy report as well. So it really made our day. We got a diagnosis. So this was a soft tissue enchondroma of the tumor mass. So what uh, the soft tissue which we were seeing on MRI, this soft tissue, okay, so this soft tissue was operated, and this was a soft tissue enchondroma which was extending inside the joint. Okay, so sometimes these patients really help you out in a lot of by doing a lot of favor, I would say, by providing great tissue diagnosis. So I did a CT cut after this biopsy was given, telling the patient that I need this for academic. So we could see small punctate ring and arc calcifications in all these areas. Okay, but the terminal tuft area did not had any ring and arc calcification. So these were like two synchronous pathologies going on in this patient. So this was a residual soft tissue enchondroma extending in the joint, causing mild arthrosis, and the terminal tuft had a glomus tumor or glomangioma in the terminal toe. So it was a nice case to learn that different imaging modalities, specifically ultrasound, can actually make us realize that everything is not infective inflammatory. The different morphologies, the different appearances, uh, from just synovitis to a soft tissue and all, it really helps us to learn and get and evolve over time as to what we are looking at. Next is a nice case which we encounter once in a while again. I have not encountered these cases many a times, but if you see, so this was a child who had tilt one side and soft tissue thickening in the neck region. And when she presented, so we could see that there was fusiform thickening of the sternocleidomastoid muscle. And this was like a feathery appearance. It was like the just like a leaf, this muscle was looking. And this was the contrary muscle, which we could see that this is a thin sternocleidomastoid muscle. There was mild increased areas of blood flow, patchy areas, which is a normal finding. And so this was a case of torticollis. So I showed this because it's important that if we get such neck masses, we should not run away from ultrasound. Try to do it. Look at what could be the reason behind the swelling, and give a good diagnosis. So this was a short, tight sternocleidomastoid muscle. Next is a 25-year-old uh, a female, yeah. So she had swelling around the AC joint. She had weight loss, fever, and again warm to touch. So these are again routine cases which every one of you will encounter. So whenever you see a bulging collection, or a bulging lesion with erythema, redness, warm, so you all know that it's pus. But what your doctor needs more that whether it is going inside the joint, is it causing a septic arthritis? What's the status of the underlying soft tissues? Whether it is going inside the joint or not. Okay, so when we screened this patient, so we could see a large collection, which is a hypoechoic collection with mobile internal echoes. So we knew this is abscess. But what we see more is that this is the normal cortical outline of the bone. So this is the acromion, while this is clavicle. Here we could see that there is irregularity in the cortical outline. There's lifting up of the periosteum. You can see that these are certain osseous flakes here, which is just lifting up from the cortical outline. And here we can see that the collection is extending inside the acromioclavicular joint. And on doing certain maneuvers by changing the position, we could see that the collection getting extended deep to the AC joint over the over the supraspinatus muscle belly. So this was aspirated. It was very thick pus coming out. We could not aspirate much, but this was a distal clavicular osteomyelitis with AC joint septic arthritis. Next is the 32-year-old diabetic with Achilles tendon repair following a leash injury. So leash injury is like while she was taking her dog for a walk and she injured herself. So there was avulsion injury of the Achilles tendon pre-op. I don't have those images. So she presented post-operatively. So pre-op, we did an ultrasound for her. She got operated, and day 7 she presented with pus discharge. And interestingly, she had a family wedding the next day. So this was the ultrasound which we performed. So these are the post-operative sutures and thickened Achilles tendon over the calcaneum. So this is the bony outline of the calcaneum, and this is the heterogeneous repaired tissue of the Achilles tendon. And we could see there's some soft tissue coming up here with echos. And this was very, very dirty kind of a tissue. And here we can see that there was pus discharge extending from the cortical outline till the skin surface. So this is the screw, which was put in to stabilize her calcaneum with the Achilles tendon. And she had really bad situation. So this was the screw again, and here we could see that is lifting up of the periosteum. There was extension of this collection underneath in the bone and going along the skin surface with extensive edema. So this was the condition of her legs, of her feet. So how unhealthy the feet were, and she works in a very reputed big four companies of on of IT world. Okay, so on inquiring again and got to know she had psoriasis. So this is a case of psoriasis with superadded infection post-operatively. Okay. And then I've got to know that these psoriasis patients who have dirty skin hygiene, they harbor MRSA. Okay, so it's very important for us to not miss certain diagnosis. We need to tell them, we need to tell the doctor whether it's affecting the hardware, whether it is affecting the bone or not, what is the status of the collection. And her pus, actually, the culture came out to be resistant to methicillin. So it was MRSA in her case as well. So she had calcaneal osteomyelitis post-operatively with abscess along the hardware. Secondary to the psoriasis thing, which was affecting her skin. So you should know how psoriasis can be from mild skin patches to multifold areas of whitish patches with scales and to a very dirty skin hygiene, like in her case. Okay, so next case is of a young female who presented with pain in the calf region, and there were no symptoms at night or while movements, but she had nagging constant discomfort going around in her calf region for a lot of time. And when she came up for an ultrasound, we really did not find anything. But then she was constantly poking at that. I have one area which she's really tender at. So by adjusting the depth, by pinpointing, just mark that area with a marker, you can actually get to know which area it is. So when you do an axial scan of the calf region, you see two muscles, which is the medial gastrocnemius and the lateral gastrocnemius, while the muscle underneath is the soleus. And these gastrocnemius and soleus muscles have intramuscular veins as well. So one uncommon thing which we see along with for these patients who have pain in the calf region, whenever we have a venous Doppler ultrasound coming up, we should always rule out deep venous thrombosis, that we all do. Along with that, rule out a ruptured Baker's cyst. Okay, but when you do a deep venous ultrasound for a deep venous thrombosis, never forget to look at the intramuscular deep veins in the gastrocnemius and soleus, because there might be a small thrombus sitting up there and causing symptoms. Okay, but in this patient, luckily her gastrocnemius and soleal veins were absolutely fine, but we could see a hypoechoic lesion with a small calcification here, and there was extensive like soft tissue edema here in the soleus muscle. So this was a case of a parasitic disease, no vascularity. So this was a myocystis of soleus muscle causing reactive myositis. So these myocystis are very commonly seen. So we should all know how they look like. They can have various appearances. So now, because in this case, the outline of this lesion is not very smooth, and we see a lot of edema here. So the lesion has possibly ruptured here. There's partial leakage, and hence there is all inflammation around this. Next is a case of pain and swelling in the dorsum of foot for 3 months. Patient is a known case of rheumatoid arthritis, and he presented to sonography of foot to rule out active synovitis because the patient wasn't improving well on medicines. So when we saw this patient on an ultrasound for the foot swelling, we could see that there was some bony elevation in the metatarsal. Okay, and here we can see in the metatarsal shaft, there was again a bony elevation here. So when we look at the long axis image as well as the short axis image, we could see that there was a bony bulge here, a ridge here, and this looked like that there's a periosteal elevation. There's a callus coming up, and here we can confirm that these are like two bony things here. So definitely there is some reactive bone formation happening. So this is a normal cortical outline of the third metatarsal, okay? And this was the second metatarsal with a bump and again a cortical outline going forward. There was subperiosteal soft tissue fluid or edema, and this was the site of her localized tenderness. So we got a X-ray done for her, and we could see some fluffy periosteal reaction here. So this was a case of stress fracture in a patient of rheumatoid arthritis. Okay, because they are on steroids, they develop osteopenia, the bone density reduces. And on X-ray, surprisingly, we had a fracture here of the fifth metatarsal as well, where she was not symptomatic. So stress fractures can be picked up on ultrasound in a very beautiful manner. Okay, so I think we are on the last case now. So this is an interesting case which I saw last week. And 30-year-old gym freak with left arm stiffness and discomfort in the axillary region since 1 week. And he was sitting at home doing nothing except gymming. Okay, and because he is an active gymmer, he had repetitive upper arm involvement, and he came to me for an ultrasound to rule out a teres major or a latissimus dorsi injury, which seeing the requisition, even I thought that I will have to wait, just look at what exactly how to look at this thing, because I haven't scanned many patients for latissimus dorsi. So this was his picture when he came. So this was his right side, and this is the left side, and we can see that there is swelling on the left hand side of his upper limb, the arm region specifically, as compared to the right. And we could see that. So now I see while reading this case, we can see there's some prominence of the upper chest veins as well. Okay, so there is asymmetry. So I initially thought, because he's an active gymmer, that he must be having a good muscle bulk. And so this was his clinical presentation when he came. So while examining him on sonography, I could see that the pectoralis major tendon was coming absolutely well, attaching, because these gymmers tend to get pectoralis major injury quite often when they do these bench presses of abnormal weightlifting and all. Okay, so his pectoralis major, minor muscles were fine. Looked a little edematous, but sometimes with good bulk, they look like this. And the myofascial planes was fine. The intramuscular plane looked absolutely okay. So while coming to, because he had nagging pain again in the axillary region, I thought I would look for any stretch injury or anything like that for the vessels. So, but the axillary vessels looked fine. Okay, these were compressible veins. we could see some ulnar and median nerves coming up from the brachial plexus. Okay, so after looking at, after examining for his latissimus dorsi and teres major. So these muscles absolutely looked okay. The myotendinous junction was fine. The bony attachment at the humerus was absolutely okay. But then again, it looked like it had some kind of, edema in the muscles. But, and along with that, there was some subcutaneous edema as well. So this was a comparison to his opposite side. So whenever you are not finding anything, just compare with the opposite side. You will get to know whether you're looking at a normal thing or an abnormal thing. So this was the left side, which was affected, which he had unilateral swelling, and this was the right hand side. So again, we can see that the right side is absolutely normal, while the left-sided muscles were edematous, and we can see all the fibrils, the muscle, the myofibrils arranged so well here, separated by edema. Okay, and while I asked him to change various positions while examining, I could find that there was an echogenic filling defect, a material in one of the vein, just proximal to the axillary vein. So axillary vein had kind of, as we saw that there were certain echos here, but this was compressible. But when we looked at the subclavian vein, it had a thrombus. So this really, was a life-changing, a life, changing diagnosis for him, because he had to undergo an urgent treatment. So this was a long segment thrombosed vein right from the axillary region till the level of his, what you call, the infraclavicular region. So it was a long segment thrombus in the subclavian vein, uh, which we could see. And this was a thrombosed vein extending into the tributaries. And there was extensive edema in the subclavius muscle in the adjoining myofascial planes. It was okay. So I'll just share a scene image that we can see that this thrombus getting extended in the main subclavian vein, extensive edema around the vein, and the echogenic thrombus extending in the tributaries as well. And we can see that the axillary vein is compressible here. So this was a site where there was, the flow was actually getting impeded, and proximal to this, I mean distal to this, there was thrombus. So this was a nice case which we diagnosed on ultrasound last week. So this has been referred in cases of specifically the gymmers, the shoulder, the people who use more of their shoulders while doing upward abduction and all those movements. Those who have a narrowed thoracic outlet. So this has been described as a thoracic outlet venous syndrome, or called so as you can see that these latissimus dorsi and the teres major are quite involved in such activities, and he had pain in the axillary region. So whenever we have such cases, if we are not finding anything, always look for the vessels. So this has been described as a Paget-Schrotter syndrome, or the effort thrombosis, which occurs in weightlifters, wrestlers, baseball pitchers, tennis players, due to forced abduction of the upper limb. So I think on a Saturday, these were the cases I wanted to share with all of you. And we have spring season starting up from tomorrow. So I wish you all a very happy Basant Panchami, and uh, all you should all bloom like these flowers, learn every day, because patients are our best teachers, So we learn from them through because that's the only way we can evolve in radiology. So if you have any questions and discussions, we can uh, discuss now.
Thank you so much, Gaurav, for such interesting cases. Uh, there are few Q&As.
Yeah. Okay, so
Will you like to have a look? Because I think that is one of them is just looking like an answer.
I will just start from the beginning. So psoriasis with gout arthritis, periosteal enchondroma. So yes, so when I looked on the ultrasound, I thought it's a gouty tophus. In the case, I will share again. So the case of soft tissue enchondroma. So I thought that it's a gouty tophus, but then the patient really helped me out to with his histopath diagnosis. So the teaching point in this case was that ultrasound really helps us to, kind of be a collaborative modality with with MRI, and makes us job easier as to what is happening in the bone, in the joint, and what's the morphology of the soft tissue. Along with that, this patient had a different morphology lesion in the toe tuft. So this was an interesting case, which I thought that that will help us to use this modality even more wisely. So there's a remark here that why it was not gout this foot case. Any imaging differences if no clinical history? Yes, so gout is a reasonable diagnosis, but then the answer came with biopsy because there was never any CT done or anything done to rule or ultrasound done to even rule out that these were calcifications or not. Okay. So, any possibility of Geyser phenomena could be possibility in AC joint case. So yes, so Geyser phenomena happens whenever there is a full thickness tear of the supraspinatus and the rotator cuff tendons. Here, the rotator cuff was absolutely okay. She's a young female, so definitely, and she's not
The
into.
PIP.
Uh, am I audible?
Yeah, yeah, yeah.
Okay, so Geyser phenomena happens when the joint effusion inside comes up like comes up like a mushroom and pops out in the superficial soft tissues. Okay, so AC joint was an infection case. We could see that there is osteomyelitis, the features of osteomyelitis in the form of irregularity in the bony cortex, and it was extending deep over the supraspinatus. So is it Paget-Schroeder syndrome? Yes, you made a right remark, Vivek, here. So axillary thrombosis, the axillary vein was fine. Only the subclavian vein was involved, though axillary vein can also be involved in such cases as it has been described in literature. So many doctors have said here as a PS syndrome. So that's a good catch. So it was a learning case for me. I think uh, yeah, so Madhu says that he has recently reported right pectoralis major tear, plays cricket activity, vessels were normal. So good, because pectoralis major is one of the most common tendons which is affected in such cases after a sporting injury or after a gym bench pressing and all. I think I have answered almost all the questions. So quick. I think Ankita, are there any more questions?
I was just talking, being mute, and sometimes. So sorry. Yeah, so I think you have answered all the questions. Uh, there's one question which has just come up. What all pathologies should we look for in acromioclavicular joint? Would you like to answer that also?
Yeah. So a acromioclavicular joint is one of the joints which is affected in almost all the individuals as they age, but they may or may not be symptomatic. So whenever we do shoulder ultrasounds, most of the times we find that the patient starts to develop AC joint capsular thickening, okay, or there are irregularity along the bony surfaces because it has fibrocartilage. So that's not very commonly seen, but the first thing is the capsular thickening. So if the patient is tender to the probe when we are pressing while examining the AC joint. Okay, so that is one. So degenerative processes, the AC joint arthritis, which you will commonly see while you do your MRIs or ultrasound. Okay, second pathology, what can happen is an infection or inflammation. Infection can come either as a hematogenous spread in the form of osteomyelitis or when certain, I would say, when we use non-sterile precautions, even while doing dry needling. So I have seen one doctor here in my city uh, who is who became a victim of this dry needling from through a through a chiropractor, I would say. So a dry needling was performed without cleaning the skin surface, and she developed severe osteomyelitis of the clavicle with AC joint involvement, and ultimately her clavicle had to be taken out from like for a particular segment. So that was a bad infection which we saw. Then a clavicle can be affected in cases of gym goers. So distal clavicular osteolysis is one of the common areas which will be seen because these gym freaks, now every hook and corner of the city you will find big gyms, and the trainers there are pathetic. They will never give you the right advice, rather they will spoil your joints unless you are aware of what you are doing, because whenever you exceed your limit, things will start to get worsen after a particular set point. So distal clavicular osteolysis is another area which we encounter. Okay, then parathyroidism, the primary, it again can cause uh, distal clavicular osteolysis. Rheumatoid arthritis is again a cause of distal clavicular osteolysis. Okay, other than that, tuberculosis, SAPHO, and all those inflammatory things can happen. Again, in cases of trauma, wherever there is disruption of the coracoclavicular ligament, there is involvement of the AC joint, can happen post-traumatic. So again, there is a Rockwood classification, which can help you to classify whether there is associated injury to the CCL, the conoid, or the trapezoid ligament, the status of the deltoid and the trapezius muscle, and accordingly, there's a big list of that classification staging. So I think these are the common ones which we see.
Yeah, yeah, I think you have summed up everything. So I think thank you so much, Gaurav. I think it was pretty interesting cases. Like I think it would be so difficult to get to answers. And the most important point which I felt you mentioned is like talking to the patient, right?
Yeah. And I think multimodality evaluation. So we should just try and ask for x-rays. We can try to do ultrasound because that's how we learn to do ultrasounds.
True, true. Perfect. Thank you. Thank you so much, Gaurav, for taking such an